We said earlier that all monochorionic twins, because they share this one placenta, are connected under the surface by some of their blood vessels, which allow them to transfuse blood back and forth. Because they're identical and they have the same blood type, this is not a problem, as long as they send the blood back and forth evenly. And 90% of the time, this is what happens. But 10% of the time, one twin sends blood to its co-twin and doesn't get enough back. And when this happens, we have twin-to-twin transfusion syndrome, or TTTS for short. To fully understand this, we need to look a little bit more closely at the geography, if you will, of these blood vessel connections. First, when we think of blood vessels, we have to remember that there are only two kinds of blood vessels in our body: arteries and veins. What makes them different is that an artery is surrounded by a thin layer of muscle, which allows it to pulse. And the purpose of a blood vessel pulsing is to be able to send the blood in a direction. Veins don't have any muscular layer, and they can't pulse or send blood in any direction. That's why when an artery connects to a vein, the blood will go from the artery to the vein, forming a unidirectional channel or a one-way street. We call these arteriovenous one-way streets AVs for short. There's another kind of connection that, if it exists, is really great and quite protective. Every now and then, an artery from one fetus can meet with another artery from the other fetus. Because each artery has a pulse and is large, these kind of connections allow bidirectional flow. In other words, unlike a one-way street, they act more like an avenue, relieving the traffic pattern. And if a pair of monochorionic twins is lucky enough to have an AA, it will serve a major protective function against forming true twin-to-twin transfusion syndrome. Having one doesn't make you immune from developing TTTS, but it significantly helps. Here's what happens, especially when there's no AA. Let's say there are 3 AV connections going from twin B to A, but there's only 2 AV connections coming back. Over time, twin B is going to send more blood to twin A than twin A can get back. If there were an artery-artery or AA connection here, it would help make up for this imbalance in vascular connections. But without one, twin B will keep donating blood to twin A and will become anemic and have a low count of red blood cells. All of us, including fetuses, need these red blood cells in order to carry oxygen to our tissues. So you can imagine without enough red blood cells, over time there can be some significant damage, especially to tissue that's very sensitive to oxygen, like brain or the heart. Meanwhile, in this example, twin A is overloaded with blood that it can't send back to twin B. It acts as the recipient. The recipient twin's heart has to beat all this extra blood around its body, which puts quite a strain on it. The way we see this, though, is as a difference in the amount of amniotic fluid around each baby, because having too little or too much blood affects how you pee. If you have too little and you're anemic, you're trying to hold on to everything you've got. The body sends the blood preferentially to the brain and the heart and slows down the kidney function. You try to hold on to as much volume as you can, and you pee as little as possible. On the other hand, when you've got way too much blood, and you're overloaded with volume, the body revs the kidneys up, and you try to pee it off. Amniotic fluid is actually just baby pee. Unlike what we think of as urine, in fetuses, it's not really a waste product because they're not eating yet. It's more a part of their circulation and development. They swallow this fluid, it helps them open up their lungs and their GI tract, it gets processed through the kidneys, they pee it out, and they swallow it again. So the way that we can tell that twin-to-twin transfusion syndrome is happening is that the donor, who's anemic and is holding on to everything, is not peeing enough and has very low amniotic fluid volume around it. The recipient, who's overloaded, is peeing like crazy and has way too much fluid around it. Ultrasound is used to be able to find how much fluid is around each baby and to be able to detect twin-to-twin transfusion syndrome. We look individually at each sac and measure the deepest pockets from front to back. In order to have true twin-to-twin transfusion syndrome, you have to meet very specific criteria. One twin has to have 2 centimeters or less of amniotic fluid, and the other twin has to have 8 centimeters or more of amniotic fluid. In other words, at the same time, oligohydramnios in one and polyhydramnios in the other. The numbers 2 and 8 are actually really important because there can be variations in what a normal amount of amniotic fluid or baby urine is at any given point in the day. And so the numbers really need to be at the extremes of being low or being high at the same time in order to be reflective of twin-to-twin transfusion as the underlying cause. Once you meet the criteria of having less than 2 and greater than 8 at the same time, we have to determine what stage of TTTS you have. Stage 1 simply means that you meet the criteria, and nothing else other than the fluid abnormality is wrong. If the donor twin is so anemic that it's holding on to everything and actually slowing down its urine production so much that its bladder is no longer visible, that is stage 2. To have stage 3 TTTS, we see evidence of too much strain on the recipient's heart. Also, if you don't have an AA connection, there are certain umbilical artery flow abnormalities, or Dopplers, that indicate worsening health for a fetus. If you do have an AA, these Doppler abnormalities may actually be a false signal, and we'll talk more about that. Stage 4 TTTS means that the recipient twin's heart is under so much strain that it's actually developed heart failure. This is called hydrops, and the word hydrops is Latin for fluid retention, something that happens when the fetal heart starts to fail. Stage 5 TTTS unfortunately means that one of the fetuses has died. In our experience, the most important differentiation is whether you are still stage 1 or if you've developed stage 2 or worse disease. That's because if you have stage 1 TTTS, there's a 50% chance that the situation will improve on its own. It turns out the fetuses who have an AA connection to help them find some balance of this abnormal blood flow, those fetuses can correct the situation or keep it at bay without getting worse and ever developing stage 2 or worse disease. The other 50% roughly, who likely don't have an AA to protect them, will progress and have stage 2 or worse disease. Once you have stage 2 disease, there's an 80 to 90% chance that you'll lose one or both fetuses. Stop and think about that for a second. The difference between stage 1 and stage 2 is phenomenal. To go from a situation where you have a 50% chance of getting better on your own to one where there's an 80 to 90% chance of actually losing both twins is really night and day. And that's why we make such a big deal about differentiating between stage 1 and stage 2. If you have stage 1 disease, we'll work really hard to try to demonstrate an AA, which gives us some reassurance that we expect things to remain relatively stable, hopefully. If we can't find an AA, that doesn't mean one isn't there, but to keep the twins safe, they'll need very close surveillance with ultrasound to either demonstrate that they remain stable or improve, or to make sure that we catch it if they progress to stage 2 or worse disease. When TTTS is stage 2 or worse, the best treatment is laser ablation. Fetoscopic placental laser ablation is a procedure that involves inserting a 3mm scope into the uterus and using the small camera that's embedded into that scope, find the blood vessels that are causing the transfusion, those one-way AV connections, and burn or ablate them using a laser. Laser definitely has risks though. After all, we're putting a device into your uterus and into the amniotic sac. The amniotic sac is like a balloon, and you would think that if you put a sharp object into a balloon, it's likely to pop. Well, there's a 10 to 15% risk of something going wrong with a laser. That risk does include breaking your water or breaking the sac, going into labor, or losing the pregnancy altogether. 10 to 15% is not a small risk, and under normal circumstances, we'd take that very seriously. For comparison, we know how much people worry and fret over whether or not to get an amniocentesis done, and that has a 0.25% risk, or 1 in 400, of something going wrong. The reason people take a 10 to 15% risk is because the alternative to not doing anything is an 80 to 90% chance of losing both twins. And given that, doing a laser makes sense if you want to do everything you can to continue this pregnancy. Unfortunately, though, although laser is the best treatment available for TTTS, it is far from perfect. The likelihood that you will end up with 2 surviving twins is only 65%. You have an 80 to 85% chance of at least 1 surviving twin. Perhaps most importantly, infants who survive, who've had twin-to-twin and were treated with laser, have up to an 18% chance of a long-term neurologic injury. 1/3 of these injuries are pretty severe, like cerebral palsy, and the other 2/3 are milder, including things like learning disabilities, developmental delay, and milder cognitive deficiencies. The single greatest risk factor for having one of these neurologic injuries is being born at an early gestational age. And unfortunately, twins, especially monochorionic twins, and certainly monochorionic twins who have been complicated by TTTS and required laser therapy, are at risk of being born early. That said, the average age for delivery with a successful laser is 35 weeks, and would be considered an excellent outcome.